You're, whatever it's recording, okay?
All right.
And you may as well close the door.
Yeah.
Okay. Yeah, great. Okay. So, thanks, Brian. I'll talk to you later.
All right. Bye, Lon.
Okay, so I'll be coming in and out a little bit.
Okay,
but you're
great.
ready to go. You're
All right.
recording.
All right.
Audio is on, just so you know. We can
Okay.
cut all this stuff that we're talking about after, so don't worry. But if you want to turn the audio off, just go like this in the middle of any of those.
Okay.
This is. This and it's green. There's no
Okay.
icon.
So we're now recording, guys, today's class. So today we're going to review chapter 13, which is psychological disorders. And we're going to be going through and talking each of the disorders. And so this is one of our last learning outcomes. If you look at your learning outcomes, so it's like understanding the psychological disorders and how they relate to behavior, human behavior, and also what we're going to be talking about next class, which will be after the Christmas break or holiday break. And we're going to be looking at treatment. So last week we talked about anxiety and sleep and how the two, so we're recording right now. We're going to talk about sleep and anxiety, and we talked about how the two connect. Hi Jay, here's our guest. Hello, Mr. Jay Harrison, come on in. Jay Harrison is our guest today. I'm just going to go through a couple of the slides and tell you what we're doing today, and then I'll get Jay to talk, okay, about some. So, I'll introduce Jay in a minute, but we'll just kind of go through what we're going to talk today. So we are going to have a guest speaker today. We're going to look at a little bit of the TED Talk that I posted. I posted a bunch of them for you, and you guys were supposed to hand them in for the self-reflection and the self-reflection bonus.
Text me if you need me.
I think some of them are still due today, but I'll double check those due dates. If it needs a couple of days, let me know, and I will extend the deadline. So just really let me know. We'll be flexible. So we're going to talk about trauma and stress. We're going to talk about OCD, somatic disorders. So they've now changed the old name was hypochondriac, so illness, anxiety, and conversion, dissociative disorder, schizophrenia, personality disorder, and depression. So that's a lot to go through today, and so that's what we're going to try to get through. So I just want to start by just talking first about the chapter. So in your content on DC Connect, I have negotiated with the publisher that you have another textbooks chapter, because your textbook on page 369 and 370 has a description of schizophrenia and all different types of schizophrenia, like paranoid schizophrenia. There's a list of 7 or 8 schizophrenias. However, the last DSM found them not very helpful. So, because the key symptoms of schizophrenia are the hallucinations and the delusions, and whereas the classifications really weren't that helpful to diagnosing or helping the patient and treating the patients with schizophrenia, and so they were removed. But this textbook, our textbook, still has them in, and so I found it confusing for students. They have almost 2 pages of content. And then at the very last page of the line, it says, this is no longer valid under DSM-5. So I have a bit of an issue testing you and you guys learning information that has been found not to be valid. So what I negotiated with the textbook, because I complained that they had this, it's now 2 editions from this change. And so I had complained, and so they gave me the chapter from another textbook. So you'll see that one if you want to use that textbook, that one, or make sure that you don't read that section, because I'm not going to test you on it because it's not valid. Okay? I actually redid the textbook last semester, but it was like, we have 2 courses, and so I thought it was just easier to leave it and have it available online. All right, so one of the things when we talk about mental health, we have to create some safety around it. Because in every class I have, there's people who actually themselves experience it, family members experience it, right? Because it's a large portion of our population that all of us are going to know someone who has had some experience with mental health and mental disorders, right? And like last year in one class, a student that week had a friend from another university that they went to high school with had committed suicide. This is a real problem that each of you face in your everyday lives, right? That you're connecting with people and you're concerned. And it's like, so when we're talking about this, we want to make sure that our class is a safe place to talk. We are recording it, so we want to make sure we don't give any identifiable information because we're recording this lecture. So if you guys want to talk about something, don't use the person's name or anything identifiable, right? So, oh, you know that girl who usually sits in that row who's in my ECE class? Like that kind of it. And any information where somebody would know who you're talking about, right? The other thing is that this could bring up some feelings, and so we want to make sure that you guys know that there's services here on campus and ways that you can help your friends to get services. The other thing is we want to know about language. So we don't use the language of the schizophrenic, right? We use the person with schizophrenia, first, third person, second, and in the TED Talk she talks about this. First you're a person and then you're the person with the disorder. You're not a disorder, you are a person first, right? The other thing is we have all kinds of language. I myself struggle with it all the time. I use the word crazy. I never think of it as mental health. I think of it as like a wild day, or that was a lot of work, and yet we use this vocabulary, crazy, all the time. And often it's like when we use this language, it can be really offensive to people. So we have to really watch our language and apologize for our language so that we're not increasing the stereotype. Right? Because, as we know, there's a huge stigma around mental health, which is one of the things that impedes people from getting help. So why do we want to study this? Why is it important? Other than it's part of my course, and so to get this credit, you have to take it, right? But the reason I think this is one of the most important parts of it is that we all have a responsibility to improve the mental health agenda of Canada. It's probably one of the most important political agendas of today, in that we know that it affects so many people. People with mental health disorders have been inhumanely treated, and it's sort of a last frontier where we're still fighting for human rights. We also have communities like our Aboriginal community who, because of the cruel treatment, as we talked in development, are suffering with mental health issues. And so it is an area we have to become aware of as a citizen. But the other problem is that a lot of times people never go for help. And so you may be the only person that person ever has contact with, and you may make the fact that you've learned some of this information, you may make the difference of that person. And for that person of getting help, you may be the person's resource, and you're going to be the person helping them get some assistance. And so that's a really important thing. The other thing is the stigma. Watching our language, having conversations with peers. We're not going to change stigma without each person being informed and thinking a little different. That's why I have all the TED Talks, so you can hear from some of the people that suffer from the disorders. I think they're pretty powerful. Which ones did people like, or did you guys get to watch some of them? Anybody watch any of the TED Talks from the people with mental health disorders on the weekend? Yes, Tracy.
Kevin Brill won on depression.
On depression. And he was a comedian.
He did a very good young man. He talked about it really good.
Right.
I found not many people come out to talk about it, and the first step is to come out.
Right.
And say, I suffer from depression.
Right. And I mean, we've had famous comedians, Susan, Robin Williams, and so it's like we think of comedians as not having depression, right? Oh, he's really funny. How could he have depression? He seemed to be coping, right?
And very popular in school.
Right.
Good grades, everything.
Right.
And,
yeah, and so So it's like some of our narrowness in our thinking is around what does it look like when someone has depression. So these are the things we need to be thinking about. The thing is, this is very current to your age and to your is that people between 15 and 24, this is the second leading cause of death is suicide. Right? This is like the most important thing that you can learn about is because you're more likely to experience a friend committing suicide or feeling depression and committing suicide than any other thing that the person's going to have died from. Right? Car accidents are number one for your age group. Second is suicide.
I don't know about that nowadays. Overdosing.
Right now, overdosing. Absolutely. We're having a huge crisis. And last semester I had a student whose partner died from overdosing. We are absolutely having a crisis. So probably there's been a huge increase with the drug overdose. So
that could also deal with mental health too.
Right.
Hand in hand.
But when we talk about comorbidity and when we talk about the last class when we talk about drug addiction, a lot of times persons with mental health disorders also use 30 to 40%. And they're trying to self-medicate. It's not that they're, they're just not making rational choices. That could be it. But a lot of times it's like they're trying to self-medicate, right? So this is like an important topic to you guys, right? And it really affects everyone. We're starting earlier today, so we don't have our whole class because some people may not have realized we were starting early. Our class actually starts at 10, but we're just like doing a little bit extra. Okay, so how many of you would tell a girlfriend that you're just starting dating that if you had mental health? How many times would you tell an employer? It's like you're going for an interview. Would you say to the employer, I have mental health issues? Right? I suffer from depression. I have schizophrenia. How many people would tell their employer? No one? What about partner? You're getting married. Yes. You tell your partner. So more of you would tell your partners than your employer, right? Right. So it's like I asked this question because it's like it makes it more real. It's like when you have to actually think of you having this conversation with somebody you care about, how willing would you be to disclose that information? Could you see it being difficult? Right? What if someone told you that and you were dating them and getting married? Would you end the relationship? Would you think about ending the relationship? Would you tell your girlfriend they should end the relationship? Yes.
I actually had a coworker actually come and talk to me. And so I sat down and talked with them for a bit. And I said, well, first you have to work on you. Come to the point where you can say, okay, what am I going to do to change that situation? What am I going to do to change that to better me? To make it better for me, to make it better for the people around me.
So the person was disclosing that they had a mental health disorder. So you want to reflect about what do they need to do to take responsibility and to seek help or
instead of blaming everybody around them, what am I going to do to change that?
Right. And sometimes when people are paralyzed with depression, they can't take action. Right? So just to give you the heads up, just that sometimes when you're in that really dark place, that's the problem, is that they don't know, or if they're anxious and depressed, they're afraid of taking the wrong action, right? So it's really hard, right, when people are reaching out. It's hard to know what to say, right? And yes, it's important. So you have to first ask them, can they take action? It's all great we have this thing when we know that cognitive behavioral therapy works as well as medication. And we know exercise works as well as medication for depression. But how do you think somebody who's depressed, how motivated do you think they are to go for a jog or work out? What if they've never jogged and now they come to see the therapist and the therapist says, oh, I think you should be exercising. How many of you guys went for a run this morning? Yeah, good on you. Right? In this cold too. Right? But how it's like, so when we think of it, it's like sometimes the activation is a really important part of the treatment. Hi guys, welcome. We have a speaker. We're just kind of creating some safety and talking a little bit about having the conversation about mental health. So what kind of supports do we have on campus? Does everybody know where the campus health center is? I walk people there all the time. Nobody seems to know where. Down by the gym. Do you know where the gym is? Everybody know where the gym is? Yeah. So I always think of it's like it's towards the north end of the campus, so the north end corner. Just past Justice on the lower level is our gym, and that's where our health center is. And we have a physician there, and we have psychiatric nurses. And then they're really good at getting you external and knowing connections in the community to get you on wait lists. And you can see the family doctor there if you don't have your own family doctor. We also have something called Ask, and we have coaches, and then we have counselors in that office. Right? So what I tell my students, and every semester I always have several students that come and see me, and I say, I can't be your therapist, right? You all know I'm a psychotherapist, but I can't be your therapist because that would be a conflict of interest. But I can certainly make sure you find someone on campus, right? And find some supports. So we do have supports on campus. Some people say, well, I might not be on campus, you're going home at Christmas. One of the best connections is your family doctor. So you might have a family doctor you've seen for most of your life. That's a really good person to talk to. So again, if a friend in your residence says, I'm really feeling this way, what are you going to tell them? Hey, make sure you go to your doctor over the Christmas break. When you go home, go to the doctor, right? Because it's a good place to start that conversation, and they often can do referrals to psychiatrists. I always like my clients to see psychiatrists, so when someone comes for therapy, often referred by their family friend or by their family doctor, I like to see them see a psychiatrist. And sometimes that takes 3 to 6 months. But I always like to have an expert opinion on their diagnosis so that I really know that I'm not dealing with something that I don't know and then get into trouble and get them into trouble. So I like to make sure that we have that. One of the other things I always tell people is the walk-in clinic. You can go to a walk-in clinic, but it's not an ideal place to go to get support around counseling or around mental health. You're better to go to the hospital. Like in our area, at the hospital, they have psychiatrists, they have psychiatric nurses, they will assess, and after they do a medical check, and they will see you right away. They can assess right then and there if you're at risk. So if your friend's not doing well and you're really concerned, go to the hospital. I've walked tons of people, met them at the hospital, sat in the waiting room. Sometimes it takes a bit of time because you're waiting for the medical check before you see them. It's a great place. And you can ask, most hospitals have great psychiatric departments, right? So the hospital, it's like if you have a heart attack, you go to the hospital, right? If you break your leg, you go to the hospital. You don't go to a walk-in clinic. If you're feeling suicidal, go to the hospital. Right? Because even I found by the time people see somebody, they're feeling better. And all you want is that your friend's alive and starts to connect with the right services. So the hospitals are a great place for mental health. All right, self-help. There's lots of self-help lines, lots of websites. We have a new one for universities and post-secondary. Good to talk, and you can call it and talk to somebody. So you may not be suicidal, but you might be just feeling down. Often these self-help talk lines, they're there 24 hours. So in the middle of the night when if somebody's feeling down or your girlfriend's feeling down and phones you and texts you at 3 in the morning, instead of saying, go to sleep, I can't take it, say, you know, here's a line. I'll look on my PowerPoint, right? Write these numbers down and keep them in your room. And then if you want, you can give them to people. Or you can call yourself. And at the health center, they have fridge magnets, I think, and stuff that you can keep. And a good thing to have in every res. Right, and probably on the main floor of our reses, they probably have them. All right, well, for some of the people, I already showed my DSM. So how we diagnose, so as we talk about these psychological disorders, this is how we diagnose this. And who can diagnose? Who has the right to diagnose? Do I have the right to diagnose? No, because I'm a psychotherapist. Who has the right to diagnose?
Psychologist.
Correct? Or a psychiatrist. Correct. That's the only two people that have the right to diagnose. Psychotherapists. We have the right to treat. We don't have the right to diagnose. However, everybody studies and reads this so that we're all talking the same language. This isn't for regular average person to just get familiar and understand it. It's actually a guide for understanding the diagnosis, and it gets changed based on research. So we had a whole bunch of changes in this one from the previous one. So DSM-4 was quite different, and I'll talk to you as we go through that today about some of the changes. So the diagnostic manual, an important thing, is for professionals, for psychologists, for psychiatrists, and if you read it, it says the psychiatric manual. But when they look at research, they may bring in psychologists, they even may bring in psychotherapists. Teams of people that are experts on each of the disorder will submit research on that disorder and if there should be any changes. And then the committee makes the decision for each of them. So when we're looking at a diagnosis, so here's ADHD, there's a couple factors. So they're always going to rule it out against other things. They're always looking for multiple settings and for a period of time. So you have to have the symptoms for a period of time. In order to have it. So here's a multiple choice question. So what answer is it? Anybody pick A? So is the DSM to treat and cure psychological disorders? Is that what its purpose is? Anybody? Yes? No? No? Somebody say no. Okay. B. Is that the right online treatments? Is that what the DSM is? C. The general public and understanding causes of disorders? Nope. And D. How many people pick D? You're right. All of you are right. All right. So this is what we're going to be talking about. We're not going to get you guys to memorize 300 and something disorders and all the particulars, but we're going to go through the most common disorders today. But before we do that, I asked a friend of mine to come and speak. He's now actually he's just finishing up his master's to become a registered psychotherapist, and he's working at Lake Shore. He's done his first semester of placement, and he's doing his next placement on trauma. And he was an NHL hockey player and had several concussions. So he's a very interesting, how does an NHL hockey player get to wanting to be a psychotherapist? It seems like a little bit of a jump, right? I don't know, maybe not. No? All right, well, let him talk.
Thank you, Dr. Debbie. Thanks for the opportunity to come speak to you guys this morning.
So the camera's there.
Is over there, perfect.
Yeah, hi guys, come on in.
Dr. Debbie and I have known each other for a very long time, and just tell you, you're very lucky to have her. She is a fantastic clinician, a big influence on my life as well. So she is a real gift for you to have up here, both from an education perspective, but also a personal perspective, because she brings a very, very unique skill set to the teaching classroom and is very passionate about mental health, which has been a big influence on my life. So you're asking, how did I get from the National Hockey League to psychotherapy and graduate studies in psychology? And Debbie was obviously a big part of that, knowing her for a very long time, the impact that she's had on people. certainly got me thinking. And I came to speak to you guys today about the context of concussion specifically. You have a huge day lined up. I mean, you could spend 3 weeks on every bullet point you guys put up there. But very briefly, it was my hope today to kind of introduce you a little bit to concussion, what we know about concussion now, specifically as it relates to mental health and wellness. Over the course of my career, I incurred probably 7 legitimate, full-blown concussions. What does that mean? It meant that they were bad enough that I had to tell somebody about the fact that I wasn't feeling right. We talked a little bit, it ties very nicely to the fact that over half the people with mental illness don't tell anybody they have it. Concussions, very similar, especially in a sports environment. I don't want to let you know that I'm hurting. What happens if I'm hurting is that I don't get a chance to play, someone else takes my spot, effectively there's an opportunity to lose my job. That is a very short-sighted but very real perspective of a professional athlete who has a very short window for their career. Long-term, not so smart. So I began to see some things happening with professional athletes. I did my undergrad in psychology as I played. I finished, first major chunk of my master's while I played, doing the clinical work now. I'll be published actually in 2018, our first study on concussion, and I'm a PhD candidate at Duke University to study health psychology, specifically treating concussions with nutraceutical products, various other substances using a treatment-based model to treat concussion in a way that reduces symptoms and gets the body healing quicker rather than just sitting you down and saying, hey, you have a concussion, come back when you feel better. There's more we can do in that space, and we're just starting to uncover some of the quite simple but very effective modalities to access the brain, reduce inflammation, and speed recovery in those suffering with both short-term and long-term concussion symptoms. But I started to see really closely the lives of the individuals who were playing sports, specifically the mental health side of what athletes go through. Even those who are adapting and functioning at a high level are still at a huge risk and very susceptible for a number of pathological issues. Anxiety is a huge one. Depression, substance abuse. There are other behavioral issues that are related to that, such as violence, impulsivity. So all of these things kind of spectrum. I watched some guys suffering in silence, and we talk about that stigma as well. It's very, very relevant. The mental health stigma is not just in society alone, it's in sport as well. People often say, well, this is just my normal, or this is what I have to endure if I let someone know, just like my head injury, they're not going to play me, I'm going to need to go see Dr. XYZ, who may take this opportunity to make a living away from me, something I've built my whole life and effectively my whole identity around, which the identity of sport and sports psychology is a completely different conversation, but also incredibly impactful when I get back to concussion. And we talk about what concussion does to the brain, how exactly changes pathologically in the brain are happening, and what that means to our long-term health, especially our mental health. So one of the big problems with concussion is that nobody really knows what a concussion is and what it isn't. There's so many different definitions, ideas of classification of head injuries occurring along a spectrum. A mild traumatic brain injury may not necessarily be a concussion, but all concussions are traumatic brain injuries. So it gets very, very delicate in the language and the diagnosis. Part of the problem with concussion is that we can't really tell what's happening at the cellular level. So what's happening is that when we're having these linear rotational forces go through our brain, we're getting this shearing effect on the axon in our brain. So the nerves are actually stretching. We're getting these micro tears. And basically what happens is we're having this cascade effect, this neurochemical effect at the cellular level. Brain cells are incredibly susceptible to slight chemical changes and balances, calcium channels, things like this, sodium, and we don't store glucose in the brain, so it's very difficult to regulate. So what happens over time, cells end up dying or adapting in a way, malfunctioning. We start to see similar pathology to other neurodegenerative disorders, Alzheimer's, Parkinson's. We're seeing that concussions have similar impacts long term, and you've probably all heard of CTE. Does anybody know what CTE is, or the concept of CTE?
Isn't that damage to the brain from so many head impacts?
Precisely. So CTE is chronic traumatic encephalopathy, which is basically a neurodegenerative disease caused by repeated trauma to the brain. the studies that are coming out about that are alarming and striking with how frequent and common it is in those people who play contact sports. So we'll talk about that hopefully just a little bit at the end if I can, kind of pique your interest in your critical thinking skills a little bit. It's always my hope that we just don't take what I say or what other people are saying at, it's the truth. We can challenge and ask questions about that because there are questions about CTE that we need to ask and we don't know yet. So specifically I want to talk about, because I'm in mental health, is the impact of concussions on that. The studies that we've started to see in the last 5 years or so are suggesting that repeated trauma to the head is highly associated with mood disorders, specifically depression. If you've had 3 or more concussions, your risk of developing depression goes through the roof. Your risk of engaging in impulsive behaviors, through the roof. Your risk of ugly and violent behaviors goes through the roof. These are not just scientific studies. This is kind of anecdotal stuff as well. We see this in the news all the time. We see former military who have experienced trauma on the battlefield and physical injury having a very difficult time coping when they come home and reintegrating into society. We see professional athletes all the time, it seems, domestic violence, depression. These are all factors, and when we tie it into those neurological changes that are happening in the brain, it really starts to make you wonder if there's a causal effect here, and the accumulation of head trauma and the risk that it generates for us for developing these disorders. So it's important for us, what I want to get across is that we just be mindful of, one, what trauma can do to the brain and how it can impact our life. But most importantly is how that trauma relates to our already genetic predispositions, our environmental factors that contribute to our well-being and mental health. One of the things that I found was very, very interesting, and I was reading up again before I did this talk, was that, yes, all of these athletes are experiencing increased risk of depression, impulsivity, substance abuse. Could there be any other reason other than concussions why this might be happening? Can anybody think of a reason why an athlete might be at greater risk for depression, impulsivity, and aggression, other than their concussions?
Just the pressure to perform.
Pressure to perform. Okay, there's an environmental factor. Absolutely.
Like they lose a game, like they can be aggressive, like not with the other team.
So there's a behavioral component, aggressive nature. You guys have kind of hit it exactly right. What if they're naturally aggressive, impulsive people? So we don't quite, what are the baselines? These are the things we don't know, specifically relating to the impact of trauma on our brain that we're seeing in athletes and these increased propensities of the neurological disorders, behavioral issues, substance abuse. We don't yet know exactly what the risk is because we don't have baseline understandings of what these people's behavior is. There's a study that I was reading about the baseline of athletes with concussions who are subsequently experiencing mood disorders. At baseline, over half of them were already experiencing these issues. So kind of think of the individual who enjoys going out there and getting hit and hitting people 15 times a night. That's a different mindset than the average person. So I wanted to just give you that side of it as well, is that there is so much we don't know yet. But in the context of physical sports, concussions, and mental health, an awareness of the potential factors, especially when we're developing youth, playing contact sports. Sports has a huge impact on our lives. It teaches us so many things, but at what cost? Are we protecting our children? What can we do to protect them? To be aware of the symptoms and signs that we see of concussion, to be sure that their return to play protocols are safe and effective, and that we're not putting people in danger unnecessarily. I would be happy to take any questions if I've struck anything with anybody or wants to know about my lived experience with concussion and some of the mental health that goes along with that I've experienced either myself or vicariously through many of my colleagues and teammates, or even my professional practice now. I would be more than happy to engage in a dialogue or discussion. If anybody's open to share their concussion experience, it seems like a great time to do so as well. You also have a large roster, so it's okay.
Anybody have any questions? One of the things I remember when we had a conversation is when I think there was at least 3 defensemen that, and I know you played defense that had committed suicide, and within a very short period of time, and there was that connection with head injuries, and it really kind of spurred your interest. I mean, their stories were really profound.
Yeah, we had one really bad season. We lost 3 guys, not all on the same team, but across the league. So to lose 3 guys to suicide in a league of 700 people, that's significant. All of them had, very similar profiles. They were highly physical players, a lot of fighting, but they also had a lot of issues predisposing them. They were also had histories of depression, had histories of so looking at the struggle they went through, specifically relating to their transition out of sport, I touched on that very briefly, the identity crisis that happens for an athlete who has lived their whole life deciding that they're one thing and one thing only, and not only is that what they're telling themselves, but everyone else in the world is telling them that too. There's certainly a bidirectional effect there because the world is valuing what they do so much. Why wouldn't you as well? And then that's taken from you. And all the skills that you had are actually irrelevant to the real world. Your ability to fight or be tough or to be aggressive, those things land you in jail in the real world. They get you praised and put in the newspaper in the sporting world. So you can imagine the contrast in experience where you were once so valued for this skill set that is completely irrelevant in the general society. And you compound that with a propensity to get down on yourself and to self-medicate. The downward spiral can happen very quickly, and part of my initiative getting back into mental health is to generate more novel ways to intervene with these guys. We do a lot of work in mental health awareness. It's awesome. We need it. We need to raise funds. But it's a very, very small step. Who is actually on the front lines treating? How do we know it's working? How do we reach these athletes or these people who protect themselves and done basically their whole lives lived in a small world and never allowed anybody in because you don't understand? How do we reach them? How do we tell them, I understand what it's like to go through what you're going through? You have no idea what that's like. No one can know what that's like. I can sort of. So that was kind of my one foot through the door, is I at least share from an identity transition perspective. I know what the roadblocks are like. I know what the frustration feels like. I know how we normally like to handle our problems with aggression and yelling. And physicality don't work. We need new strategies. And just like anybody else, they need to be taught, they need to be practiced, and they need to be cultivated. But they need to be cultivated in a safe environment. And so many of these athletes don't have that environment or don't feel they can be connected to that. So my mandate was largely to help create that space, to create that awareness, that connection, and then meet those guys where they're at to provide them what they need.
Thank you.
My privilege, thank you.
Question.
Yeah.
So you said how concussions play a big deal when it comes to depression and how all those symptoms skyrocket. Does this also factor with any other injuries aside from concussion?
Oh, that's a good point. Injury in general that's a great point, because is it concussions, or is it just injuries per se? And that's a great point, because career-ending injuries, regardless of what they are associated with depression. That's a great point. It's tied to those life changes associated with that injury. Things are taken from you. You are all of a sudden, in my experience, and this is completely anecdotal, but it's disempowering. You become helpless. You no longer have control of your life, and you're someone who's so used to being in control. I can force my will on this. I can train harder. I can be assertive. With a head injury or a career-ending injury, you basically are sitting there and the world happens around you. And that can be very, very terrifying and paralyzing in many ways. So it's a very, very keen pickup on, yes, if you look at the research of sports injuries in general, they're associated with more depression, anxiety, and stress-like responses.
Okay.
Yeah.
So when you were talking about that you lost the three NHL players in that year, was that the year that Wade beat them?
Yes, Wade was one of them, yeah. Yeah.
I think it was such a surprise when he had passed or committed suicide.
Yes.
Because he was that you always portray that like happy-go-lucky, funny, like awesome guy, and then you hear that on the radio, it comes up in the hotel room, unfortunately, and
Yeah.
it's just.
That's Wade was actually a teammate of mine for several years, and you described him exactly as I would.
Well, because you see him in the parades, and you see him doing interviews, and he's just so funny, and yeah.
Yeah, I think we talked about that earlier today when we talked about the comedians who suffer with depression. We talked about Robin Williams, and oftentimes that exterior, persona and mask is often a reaction formation of what actually is happening on the inside, and it's actually completely dissociative, or a way to mitigate what's actually happening inside. It's, right.
He did have concussions, right?
He likely experienced significant over the course of his career. Maybe not as bad as some people, but definitely brain trauma was something that he likely incurred through his career.
I was just gonna say, to add on, it does, it's hard when you lose, your activity, because, I've gone through it too. I fell off, my horse, I horseback ride, and I fell off my horse, from 10 feet and fractured my back, and now I'm not even able to ride, so it's really hard.
Sure.
I really understand,
Wow.
yeah. And, I own the horse too, so, I can't,
Mhm.
he's just sitting there in the field now, and, he has arthritis, and I don't know if I can ride him, so it's kind of hard, but,
Sure.
Huge loss.
yeah.
Sometimes you don't realize how important things were, and then you're faced with it every day. Now you see your horse every day. And
Yeah.
Think about what used to be. It's difficult.
I have one last question. This kind of it doesn't really relate to athletes, but more like celebrities. And they over the past couple of years, a lot of celebrities have been taking their lives as well. Like you said, Robin Williams.
Mm-hmm.
I forgot the singer of Linkin Park. He took his life yesterday. And other celebrities in the past. I'm just curious on your intake. Why does even though they have such a amazing lifestyle, and they may deal pressure here and there, why do they choose to take their own lives when they have everything mostly going for them?
That's a great question. It's been hard for us to understand. Very similar to the athlete experience. How could you be depressed? You make millions of dollars. People worship you. It's from my perspective, at least as a clinician, there's a lot of things that you have to give to receive that kind of adulation. Specifically, you create a persona. You become something that's probably not you, which is the hardest part. So every day I go out there and I dance over here, but the real me is crying over there. With very little time or emphasis placed on caring for that, because everyone wants to see this. Certainly, artists generally deal with, if you look at historically, great artists often suffer a lot of pain. A lot of the greatest inspiration comes from the deep conflicts within them that they're able to express for our enjoyment, much to their own misery. You think of a few that come to mind, guys like Beethoven and that, who produced some of the most beautiful things, but the internal conflict that he experienced and what that was drawn from, is very similar to the comedian who makes everybody laugh and is crying. But there's certainly a lot of environmental things that go on. There's exposure, there's risk factors. Certainly there's some personality issues as far as, again, what people are giving back to me and what people are valuing me for. I find sometimes that lesser, not as pathological, but the more people adulate me for something I'm not, the less I think of myself. And the less I think of you, because you believe this sham. Right? It's kind of I fooled you again, so I have absolutely no respect for you because you think that's all I am, and I have no respect for me because I had to go out there and do that to make you like me. Right? It's a kind of a dangerous, internal conflict that many people have to give to be famous, and oftentimes we don't see what happens behind the scenes, what it takes to do that, and the internal strife, whether it be what it takes to get there. From an athletic perspective, the training, the travel, the sacrifices. I'm sure it's the same with actors, musicians.
Yeah.
I mean, I couldn't imagine being a musician trying to make it, playing three nights in a row on these dive bars in front of 75 people until somebody sees me. You can imagine the grind that is and the toll it takes on you to reach that level. And once you've reached that level, then there's some environmental factors as well that can really contribute. Substance abuse is probably the biggest one from the self-medication perspective. How do I get up for this? How do I get down from it? I don't know, but it's being in a room with 25,000 people screaming for you. That's a high that doesn't go away very easily. So oftentimes you got to find ways to come down, to sleep, and then get up and do it again tomorrow, and you end up in a vicious cycle. And that's, you know, a behavioral environmental factor that can also contribute to how things spiral out of control. You don't need to be sick to commit suicide or to get on a, you know, a bad track. I think it's important to talk about, you guys mentioned the DSM. I'm a counselor in the States, so I have to use that in order to continue to see people. And from a counseling perspective, I'm sure Debbie will talk about this before, but is there any danger in diagnosing? Like, does anyone have a problem with it? Is it necessary? Like, I have a problem with it. Because as a counselor, I'm here to help you achieve wellness and find, you know, your path forward. How can you help yourself? I come here and slap you with a diagnosis, say, boom, here you go. That's what you are now. Good luck. You know, it really externalizes what you're suffering from who you are. You know, we talked about that at the beginning. You know, you're a schizophrenic now. You're diseased. You're damaged. You know, I'm not a person who's suffering schizophrenic symptoms. I'm not experiencing depression right now or anxiety. I have an anxiety disorder. There's nothing I can do about it. Medicate me, please. I think we're starting to see the dangers in that perspective in mental health and over-medicating. It's like kind of taking a diet pill without going to the gym.
That's what I was going to say. It's like masking the diagnose with the pills and medication. Because then you get immune to them, so they just keep on upping you until you're like at that point where you're like, I don't want to do this anymore, and then you just overdose it.
Right. So there's some huge issues in the diagnostic model, that disease model, the medical model, when dealing with mental health, and it's not the whole story, especially when you're working in a clinical perspective, when we're looking at trying to increase wellness, or you get people back on track and get their lives in a place where they're finding quality and achieving their goals, right? Acclimating that potential within them. That requires empowerment. And oftentimes a diagnosis can be, you know, very, very much a hindrance, a very negative label, a self-label, and then you tell yourself these things. And it's very difficult to overcome at times.
I remember once I was meeting with a student, and I said, you know, it could be that you have a bit of depression. And they said, what are you telling me, I'm crazy? I said, no, it's not that you're crazy, but your neurology, your brain might be, you know, reacting in such a way that, you know, for some disorders, medications are really helpful. And for others, they do very little. It's, you know, and then it's the right medications. And then that in itself can be a journey that's horrific. If you've tried 5 or 6 different medications and none of them work, what's wrong with me? Why did they work for me? And yet, this person over here, who I started a group with, they're great now, right? Because they've responded to the medication, right?
I'm currently working with a lot of patients experiencing schizophrenic symptoms or have been labeled with a schizophrenic diagnosis. 50% of them have treatment-resistant schizophrenia. Schizophrenia is very difficult to treat medically, but they're all on treatment. And you can actually see, I call it the psychologicalization of them, because they talk in the psycho-speak and refer to themselves as illnesses, or I can't overcome this, or if they have a problem, it's automatically because of their illness. They have a difficult time making a decision that any of us would have a difficult time making. And like, oh, my illness is really impacting my ability to make a decision right now. Meanwhile, you or I sitting in the same chair with the limited information they have would be having the exact same problem. You know, but rather than say that it's my problem, this is a human problem that I can solve myself. Now I have an illness and I have medicine for it. Why isn't this working? Some of the things as a clinician, I'm sure, Debbie, you know, you've come across and I'm starting to experience as well. So just a little food for thought, and, you know, the two sides of the diagnosis spectrum, and as you guys go into your talk about mental health. Yeah?
I was just going to say, like, I think sometimes there's like a misdiagnosis as well. Because
Yes.
I know I have a friend,
Huge issue.
I had a friend, she was like, you know, anxiety and depression, but they didn't realize she was also like borderline personality. So she's just being treated for anxiety and depression, and then like now she's doing a lot better. She's on proper medication and stuff like that. But again, it's taken 5-10 years to actually get her that diagnosis.
Yeah, and that's a shame.
The study that
That itself is like, oh my God.
yeah, well, they have these studies where they present a client, they have 10 different clinicians in the room, and they ask to diagnose all on the exact same behavior, and then all 10 of them come up with a different diagnosis. right? So although this is incredibly helpful in understanding symptoms and presentation of symptoms, we encourage everyone to look at that whole person. We're people first. There's a lot of things happening for each and every individual.
I think that for the diagnosis, that it's a double-edged sword, because when you know that something is not sitting right, you know that things irritate you that don't irritate other people, or that OCD, or you know what I mean, that you want to know that there is something. It's not all in your head. You want to know that there's a reason.
Absolutely.
Like, so when you're sick,
That's the
and you
that's
keep
the
going to the
positive.
doctor and
Yeah.
they say there's nothing wrong, you're like, I know I don't feel well, there's something wrong. That when they finally say something, that it's a relief, because you know it's not all in your head, right? That you know that there's an issue. That being said, and my pet peeve is children being diagnosed with ADHD, that on the other side of that sword, are all of these children who are diagnosed with it, do they have it? Is it a brain chemistry, or is it their environment where they're not taught patience, they're not taught to say, I know,
gratification.
like some, you know what I mean? Like some children, the TV, their laptops, their thing is all an overstimulation. So is it the chemical imbalance, or is it the environment that they're in that's producing this? And so if you're treating them with medication and altering their brain chemistry when it wasn't that to begin with, do you know what I mean? I think that people really like to label. I understand the importance of labeling, especially when something isn't sitting right with you. But like I said, a double-edged sword, where sometimes maybe there's really nothing wrong with you, you just...
Well said. Very,
Yeah, I
very well
think
said.
you've really hit
You've really summarized the...
the dilemma is that, diagnosis absolutely gives relief, provides a treatment plan. Diagnosis is for treatment and making sure it's the right diagnosis, but we have comorbidities. Anxiety and ADHD can look similar. Learning disabilities and ADHD could look similar. Family domestic violence and ADHD could look similar. So you have this child who's acting out. Is that truly what's going on with them? Right? It's a very complex thing. And then the pressures from society, oh, this child's not behaving, then I think you need to go get them diagnosed. So again, but that's up to good clinicians, right? So when you're a good clinician, you do a home visit, you make sure that you've seen the child in multiple settings. That's one of the areas for a true diagnosis of ADHD. It's to be in 3 settings. So if it's just at home, that's not ADHD. If it's just at school, that's not ADHD. It needs to be in multiple settings. But has the physician who has 15 minutes in their office, not to criticize physicians,
But it's true though.
But does the clinician, whoever they are, have the time, again, the pressures, right? Making sure that we as clinicians have the time, that we need to make those proper assessments.
Yeah.
Right, and the information, yes.
Sorry, I wanted to go back to when you were talking about the sports. Curiosity, do you find that, can you see a difference between the generation gaps in the players?
Yes.
Yes?
Yes. As with society shifting, the new players are very different. The old kind of mold of players, which I would fit into, is more of that quiet, resilient, don't tell anybody, fall into line very quickly. But we're getting, like, these kids are very, kids now are very, very forthright with what they think they should have a very difficult time falling into a pecking order or a line and waiting.
Yes.
And they have a very difficult ability coping when things don't go the way they want it to go. It is my impression that athletes, like a lot of kids today coming up, are not armed with the distress tolerance skills and the emotional regulation skills that were once required in society. It was a function of being alive as a kid. If you didn't sit at the table, you were reprimanded significantly. Now, society has changed in a way, and that's not a judgment whether it's good or bad. The fact of the matter is things have changed and our standards have changed to allow certain behaviors. But with that, there has been kind of a gap in the ability to regulate to delay gratification, and to tolerate the stress. You know, we're an instantaneous society. You need information, you get it. You know, how many people, you know, wait for Christmas to get that thing that they really want? Nobody. We go and get it when we want it. I order it and it's there in 2 days. So with that, we have to be mindful that, you know, when kids don't sit and pay attention in class, it's not necessarily a chemical imbalance, but it's a product of many different factors that no longer are the expectations on this child in their life to do that. And if we want to, then we have to change a lot of things.
Well, that's what I mean, because it's funny that, in my opinion only, when, especially in the sports, where, like you said, it's very demanding, there's a lot of pressure on you, and when you have younger children in sports where there's no score, everybody wins. Mm-hmm. And some of them that are extremely talented that move on still haven't quite, until they get into rep, haven't quite grasped the concept of losing. Mm. So during the years where that is formed and how you can deal with it easier. When you're younger, you can deal with it a little bit easier than when you get older because you're more hard set into, I don't lose. Mm. That being said, how does that transition into the younger players now in the sports where they don't tolerate losing, or losing isn't, they can't handle the feeling.
Yeah.
And then, as you said, the fans yelling at them for losing. So they've already upset within themselves because they never lose.
Right.
Do you know what I mean?
Sure.
But is that such a bad thing in sports to teach young children? Because does it not motivate them? Nobody likes to lose, don't get me wrong. But in my day, that you learn to deal with it. Okay, yeah. It's either I don't want to play anymore because I'm not good, I don't want to do it, or I'm going to put that extra effort in to get better.
Sure.
Where if there's no score, how is that accomplished?
Sure, I think you're really touching on the perspective, like the value of losing, right? It's not necessarily.
Does that have an effect on
at the highest level, generally these guys are adaptive in a way that they have the skills to handle that, and usually they don't lose a lot ever, and they're able to internalize loss as a motivator. There's a really high competitiveness to overcome that, and it doesn't seem to impact their self-worth. If anything, it acts as a motivational factor. Or they have actually lower self-worth anyway, and they're constantly driving to be better. That's how they get to that level, because nothing's ever good enough. So even if they win, they lose, and it continually motivates them. The problem, what you're saying, is I suspect is in the younger age bracket where kids are not seeing the value in competition and being on the losing end and what we can learn from losing. Mm-hmm. That to me is probably the greatest gift sport has ever given me, is to know that I could lose and still go out there anyway.
Resilience.
The resilience component, you're exactly right. And like that allows me to come into this classroom, like it's not an easy thing, but you know what, I might come in here and I may absolutely do horribly. What a learning experience.
And it's not the end of the world.
It's not the end of the world, it's a learning experience that, is a continual part of my growth.
But you didn't do horribly, right? He did very well. So I think we're good. I think maybe the last two questions, and then we're gonna have to let him go.
Yeah, you guys got like half the DSM to cover today. I don't know how you're gonna get through that.
Okay, two questions. One, and then yeah.
So, can I go back to your playing time?
Sure.
How many times during your career did you have like a moment where you experienced a concussion, or you saw a teammate experience one? Then you had to ask yourself, is it really worth it? And you had to consider hanging the skates up.
I retired because of a concussion, but the concussion before that, I had a very scary moment. I got hit into the boards, and I suffered a cervical neuropraxia, which is I had a pinch of my spinal cord in my neck. Both my arms went dead. I told this to a football player. He's like, big deal. That happens to me every Sunday. But it was a big deal to me. And I got hit against the boards in a way that both my arms went dead. It felt like I actually had scalded my hands. It was weeks. And I went and saw the doctor and told him I was fine. I had 4 kids at the time, been a professional athlete for 13 years, and was 32 years old. And I still told a doctor after I basically, when I got hit, I couldn't hear anything. It was like, you know that movie, the slow-mo, like explosion on the beach and everything goes quiet? Like that's where I was. And I told him 5 minutes later that I was fine because it was a big opportunity. I was playing on the top line for the first time this season. I had a great opportunity and I didn't want to miss it. So I told myself, that was a very great reflection point for me. It's like, if this doesn't do it for you, so he says, you're crazy. And you've got a problem. You need someone to take this away from you. Because if a family, a successful career, and a budding career after, because the largest part of my life is not when I played, it's after I retired. The biggest part of my career is coming up. The most years. If you don't have that perspective yet, you're never going to have it. And that was really, really scary for me. And I look back on it now, and it still gives me, I still have to process that. Yeah, I still have to process that and where I was in that time, and the fear on both sides, the fear of not playing anymore and the fear of continuing playing, all at the same time. So it was a good question, yeah.
Yes.
Do you think, you know, when you guys start the first year, you have all your training and whatever. Is there any mental assessments as well?
This is a big issue. There isn't. Strictly speaking, from a liability perspective, when you're looking at the big politics, the big machine of running organizations, if I know about it, then I'm responsible for it. And this is a big thing that we need. The league does not want to be responsible for your mental health after you leave the game. It sounds very cold, and it is, but it's a business. I want you to go out there and play the game. You're going to do what you do, whatever, you're going to perform, and when you're done, you're done. You're being compensated for what you do very well, better than most people will ever have the opportunity to do. When you're done, you're done. You've paid the price, and you've gotten compensated. There is a movement now to say, what else can we do from a wellness perspective? I'm sitting on some of those initiatives right now, working to develop how do we get more psychoeducative material, destigmatization, resilience training for guys who are not necessarily pathological, somewhere in that spectrum on their way, or could use some help, as well as to get that baseline, to get an understanding, what don't we know yet about these guys and how does it relate to their future behaviors before we start taking the sticks and the pucks and the footballs away from 12-year-olds because of all the fears that we have. What do we know for sure? So that's a big part of my mantra and future to develop that kind of policy and make sure we know what we know before we make these decisions, both positively and negatively.
I just wonder if we could have saved some of those suicides that happened that 1 year kind of thing. Like, not that you're going to be watching them, but
well, that's it.
Was
Yeah.
Do you know what I mean?
Yeah, how do we reach them? That's the thing. We guys, they're retired. He moves to...
That was our conversation.
Yeah, he moves to Saskatchewan, he moves to California, he moves to Maine, and we're all connected by something, but we're all isolated as well. We all used to play, but now we're all doing our own thing, and it's very hard to stay in touch with people. People are hesitant to reach out, so we're still trying to find those novel ways of how do I engage you, how do I check you, how do I find out what your risk factors are? I don't even know. Like, if there's a guy with risk, do I call him every 3 weeks to check on him? If a guy has less risk, do I call him every 3 months? What is the protocol that we use to monitor without being invasive and without disrupting people's privacy? You have a right to suffer in mental anguish and have a mental health and not have anybody know about it. That's your right too. You don't have to talk about it. You should, but
We can help, right? But great questions, guys.
Yeah, thank you.
Really good questions. Thank you very much for coming. And thanks, class.
Thank you.
All right. Well, let's go back to your life and
Back to life.
training.
Life, yeah.
One of the things that Jay does is he's developed with the NHL where he's actually helping players plan new careers and doing career testing and some of that psychological assessment stuff we did in personality. He's been doing some new measures to help players be able to use that data to start planning their new lives. So he's doing great things, and we'll have to have him back again. All right, thanks, guys.
Thanks, guys. You guys were great. A Monday morning. I didn't know what.
A Monday snowy morning, right? All right. So do we want a few minutes for a break and then come back and we'll get into some of this content? All right, thanks, guys. And I think, so short break, I think they still are recording. speaker again, so we'll start back. All right, so somatic forms of disorder. So it used to be called hypochondriac. So somebody who thinks that they're sick and has anxiety about their health conditions. So in this condition, they get anxious. So if you have a stomach ache, they have researched it. They spend a lot of time on the internet now. Well, now we didn't have the internet. We'll do research into books, and they often will change doctors, right? Get second and third and fourth opinions, and they don't have a physical ailment. They may feel uncomfortable, but they think they're dying of a serious disease, right? They have a back pain. Now they have kidney cancer. So, and it's very hard to treat. Why would you think this is hard to treat? Why would anxiety illness be difficult to treat? So they think their body's having symptoms, but they don't have the symptoms. They aren't really experiencing the illness. What's hard about it? Yes.
Because they think that they have the illness, so it's kind of like a placebo effect, but the negative, like a negative way.
Right, exactly.
And then if you tell them this, then they'll be like, oh, well, now I have this. And it's just a snowball of different problems.
Right, and they become, they constantly are researching, and so they become experts on those things, and then, it's just like exactly what you said. It's like a negative placebo, in that it's reinforcing their attention. So if we attend to all our aches and pains, if we start to attend to our bodies, and we're attending to everything, we will feel a lot more than what we do normally. And so then they'll make those conclusions, right? And so they become very untrustworthy of any medical sort of facilitator or treatment, so they're not going to trust the therapist. And the big part of treatment is that trust relationship, where I'm telling you something and you're actually maybe believing me, and then, or at least challenging yourself in something, right? And so the more you can't challenge anything. You believe what you believe. How am I going to change that? Right? Yes.
It's also, with placebo, it acts like mind over matter.
Right.
Where if I say to you that my shoulder hurts, and the doctor has done all of the tests, every one of them, and no, we can't find, but you keep saying my shoulder hurts, that you put it in your mind. So you actually do feel the pain.
Right.
Except there's nothing wrong.
Right. Exactly. Yeah. Very tough disorder. Another one's called conversion disorder. And you see this sometimes in movies where a person in the war couldn't walk, or they all of a sudden and they can't move a limb, and they actually cannot move it. And it's due to the anxiety. And so they believe it's real. They can't move the limb or the area of their body, and it's related to this defense, sort of blocking out some part of their body. So, and we've seen this a lot during the war, where people would have this. Yes.
Would that also be the opposite effect too, when they do lose a limb and they have the ghost?
Well, I think there's actual.
Or is that totally different?
Yeah, I think that has actual neurological. They're feeling the neurons, even though their limb isn't, right? So the messaging is different.
So that's totally different.
Totally different, yeah. This is actually a disorder where a part of the body, you believe that you're paralyzed and you're not, right? Now, the difficulty with this, now we talk about diagnosis and the danger of diagnosis. I had a case where the doctors thought the person had conversion disorder. She couldn't move her arm, had severe pain in her upper arm. I did psychotherapy with her, and her condition kept getting worse and worse. And then she was having, feeling like epileptic seizures almost in her back, and she kept having, and so I said, okay, why don't you see another doctor? Go get a second opinion. So now I'm the psychiatrist has sent her to me. I've done therapy. I'm not believing that. I'm thinking, hey, what's going else on here? Symptoms are changing. I send her back to the doctor, send her back to her family doctor, to another neurologist. I think 2 neurologists later, she has a seizure and she had a brain aneurysm. So it was a perfect example to me about listening to the patient and checking things out. And yes, she did have some psychological issues that were contributing to her anxiety, but obviously she had a brain aneurysm. So it was like sending her back saved her life. And she had the seizure on the doctor's table, and he did the removed the aneurysm. She almost died. So I was like my one claim to fame of like send that person back to the doctor because you're thinking that the symptoms aren't what they think. So again, the danger of diagnosis and the trickiness of dual diagnosis, and if things looking one way and there's something else, not an easy process. So let's have a read of this case. So you've got a 38-year-old woman, worked as an X-ray technician. Bella would find herself looking at a piece of clothing or at a book and not remember where she had put it. She would lose time, she wouldn't remember nights that she had spent with her husband, but she didn't drink. She never drank. And she never drank to the point where she would not remember things, where she'd be blackout drunk. Bella did not understand. She really didn't like the taste of alcohol, so it wasn't making sense. But everyone thought she was drunk, had drunk too much. As her children got older, they would ask her why she was so nice one time and ignored the others. So any ideas what maybe this disorder is? No? Okay. So dissociative disorders are where people will lose tracks of time, where they will dissociate from themselves and that they will lose memories and their identity, right? And it's like they can forget who they are, where they are. And so there's different types of dissociative disorders. One's dissociative amnesia and dissociative fugue. And this is where we get the Jane Does, where people will wake up in a different city or will wake up and not know what happened. We see this when we have big disasters. So, and then the person has experienced a trauma, like 9/11, and people won't know who they are. And they may never know who they are, and the stress of what happened. And so they go on and carry on their life, never known anything in their life, right? And that's why they have the pictures and stuff, because there'll be a certain number of people. Now, some people will experience this for only a very short period of time, and then they will regain their memory, and other people, their memory will be completely removed forever, right? And so this is something, and any kind of trauma, any kind of situation like a weather condition, like any kind of a situation where there's been like a horrific trauma, you're going to have a percentage of people who are going to experience this. This is like, yeah. So I think in your textbook there was an example, right? And they will, where you get this disaster experience, like wartime sometimes, and you think of people like didn't return back home after the war, they started new lives. Well, some of them had this. Some of them may have made a choice not to go back to their wife and children, but some people actually would have had experienced this. Yes?
I'm just wondering the difference between like Alzheimer's and then...
Well, that's where you have actual brain damage.
Okay.
This is where your body is so traumatized, your mind is so traumatized, it eliminates your memory. Yeah, this is where we have the person. This is not due to brain trauma. This is due to emotional stress trauma, right? So you haven't hit your head, which would be amnesia. This is dissociative amnesia. So dissociative amnesia is a biologically based from head trauma or from trauma, where this is a psychologically based from from the emotions of having experienced it. Right? Yes. So, like in the tsunami, people had it. Right, so some of them will have it because of the physical, right? And others will be like they just didn't remember yet.
So would an example of the first amnesia,
Right.
would that be if you had a difficult labor, like childbirth? Because you hear a lot of them say, oh, it wasn't so bad, like after, not the following
Perhaps,
day.
I've never
But
thought
I mean,
of that.
like a year later, it's like, oh, it wasn't so bad. Where during that time when you were there seeing it, it was like, you were screaming. It was pretty painful.
Right.
But then, like
People
I
will
said, a year
say
later,
after.
they'll be like, oh, it wasn't so bad.
Because they just think of the baby.
Right,
And
so
other
you
people
sort of-
do remember. You know, maybe that is an example. I had never thought of it that way.
And again,
I'm
would,
not
would
really
that
sure.
would that be a for preservation? Because I mean, if you did remember how painful it was, you wouldn't want to do it again.
Maybe.
You know, so maybe there's a reason for that.
Yeah, maybe. In these cases, it's usually wartime or natural disasters like hurricanes and tsunamis and horrific events that 9/11 that are so traumatic that, you know, like an earthquake, right? People in the fires, right? There's and we're not quite sure why some people respond that way, but it could be. It's interesting. I've never looked it up or made that connection. Okay, so this is so dissociative disorders. There's other types is where people lose their identity, and we often think of this as multiple personality, and that's the term they used to give it. And we had that book, The Sybil, and it became so popular that they changed the name in the DSM. So that's one of the things that happens is like anxiety used to be called hysteria, but it had such a negative stereotype, right, about the hysterical person that they changed the name. So in this case, we had multiple personality disorders. The other thing about multiple personality disorders is people really confuse it with schizophrenia. So they think schizophrenia and multiple personalities are the same thing. They're not the same thing at all. Schizophrenia is a biologically based disorder in which the person loses touch with reality. Dissociative disorder is a memory loss and an identity loss where they have different alters, and it is created usually in horrific stress related to, usually it says like here, 95% of the time they've been physically abused. So children that have been abused, I think you could have dissociative disorder and people who were held captive. You know, when we see these journalists that have been kidnapped in the Middle East, you're obviously got post-traumatic stress. It's one of the disorders connected with post-traumatic stress, multiple personality disorder, dissociative identity disorder. So you develop different parts of yourself. And so what you'll see is a person who's maybe gone through horrific physical and emotional and sexual abuse. What happens is we all dissociate. So you know you're driving and you don't remember going through the light, or you're walking even through the halls and you got a test and you don't remember how you got from that part of the school to here. You dissociated. You're not paying attention in your moment-to-moment body. Dissociation helps us protect us of something. So what happens is when women are raped or men are raped or horrific things happen, we almost like hyper-focus somewhere else. We dissociate, we float. You know, have you ever daydreamed? You're not here, you're not paying attention, you're up here. So this is where we sort of float someplace, and then you can tolerate the pain that's happening to you. So the physical pain or the sexual pain, that you don't have to feel it because you're over here. And so it's almost like hyper-focusing. Sometimes victims will hyper-focus on the carpet, right? But yet when they see that carpet, it like freaks them out, right? They have like profound anxiety, right? And so what happens is that they dissociate. And in horrific experiences of child abuse where it's been over and over, where there's been this horrific trauma, the person develops different personalities. And we call them alters. And the average person has like up to about 10 alters. But people can have multiple 50, 60 alters, right? And they split off parts of self, and it protects them because then they can go into that alter and life's okay in that alter. And they don't have to remember. It's a psychological way to protect one's psyche and to stop from remembering and being in pain all the time. Right? So it's very effective for helping them manage the symptoms, but you can see the disadvantages for trying to live this way, right? And I do have a video. I don't know if I posted it. I have a YouTube video of a woman who has dissociative disorder, and they take her in and out of personalities. And so next class after the holidays, we'll be in our classroom, and I'll show you that video. But it's very interesting to see somebody going into the different personalities. Yeah, so I have that video there, but I won't show it to you now. Okay. Oh, so schizophrenia. People often confuse schizophrenia with multiple personality. And there's slides are skipping, sorry. I'm not quite sure why they're skipping, but they're skipping. Oh. Do I have to? Okay, so schizophrenia is the most serious of all mental health disorders. It is where the person has a complete break from reality. So they are disconnected from what's really happening here and now. And it's a small percentage of the population. It develops earlier in men, right? And there is this complete break from reality, right? And it's connected with, dissociation is connected with two kind of major symptoms: hallucinations and delusions. So thinking that something that's happening that's not really happening, and is delusions. And hallucinations are visuals, are sensory experiences that aren't really happening. For instance, thinking or feeling like your whole hand is on fire, right? Or that someone's cutting you into little pieces. And physically sensing and feeling it as if it was real. So it's not like you can separate between what's real and not real. When you're imagining you're on fire, it is like you're on fire. Remember what we did with the imagery? It's like there's no difference in the parts of the brain. Like it is, you are experiencing these sensations. You are hearing these voices, right? And it's very debilitating to be hearing voices and having, like here you're trying to listen to a lecture, but in the meanwhile you're having, oh, well you're not so smart. Why are you doing that anyway? She's going to look at you. What are you doing? Right? And so you're hearing these voices at the same time as you're trying to focus on life. Right? And you can't stop them. Right? So you're having these delusions and these hallucinations. And delusions is where like you believe these false realities. So in The Beautiful Mind, he believed he was a spy. Right? And these are really the hallmark of schizophrenia, and you can see how debilitating it is. And I posted a TED Talk for you to watch, and she's a lawyer, and she teaches psychology or psychiatry, I think. And she has schizophrenia, and she talks very vividly about her experience. Definitely a must watch. It's one of your choices. I think it's probably one of the best. So some of the other symptoms, like you're socially withdrawn, obviously if you're having these voices and hallucinations, you're going to withdraw from society. Yes?
There you go. I was just curious, are people born with schizophrenia, or is it like
No.
a developmental thing? Like
It is what we know now. I'm going to show you a video. Perfect question. How did you read my mind? So I'll tell you the symptoms and I'll show you the video. Just last year, there's new research that shows how schizophrenia is formed. And so what we now know, because we always knew that it was the late onset, actually a lot of times it's between 18 and 25, which is why we're always saying that on a post-secondary environment we need so much mental health support, is because most of the disorders actually start during this time of life, right? Young adulthood. And so adolescence, young. So what we know now is that developmentally, the brain, remember we heard about the brain needs to be pruned. So it grows, and then it starts to prune and get rid of some cells. With schizophrenia, it falsely prunes. So now your brain is eating and getting rid of, your immune system is cutting away good, healthy brain parts, cells. And so it's actually causing brain damage that then affects you. So we know this now. So let me show you this video. I can't get the video to work in this, so I'll show you it here. On here, I've got it set up. And the thing is this is like absolutely game-changing research that is all because of genetics. Remember I told you the genetic revolution that we are going to see. You guys are going to see so many changes in science because of our ability now to understand the genetical connections. This is an example, life-changing. It's amazing research. And so have a look at this.
Understand schizophrenia. There's been an appreciation of what key
okay. It's not loud.
This result is important because it points to a normal developmental process, the process of synapse elimination and interaction between neurons and microglia, as something that may go out of control over schizophrenia. And that points the light toward new potential ways of trying to develop treatments for schizophrenia.
So now moving forward with this knowledge, I think we can start to really think about ways to develop better therapeutics to block or manipulate different aspects of the complement cascade. This not only has implications for schizophrenia, but for a lot of other neurological disorders that range from autism to Alzheimer's disease.
This will turn out to be the most important break in the disease. Again, I want to be really clear, it's not going to lead to immediate treatments. We have to be careful and cautious about it, but actually understanding what's wrong with the disease is the most important thing in eventually being able to treat the disease.
So, I don't know if you really got what it was, but I have posted.
One of the things we've desperately needed in our effort to understand schizophrenia has been an appreciation of what key molecular and cellular events in the development of the illness are. This result is important because it points to a normal developmental process, the process of synapse elimination and interaction between neurons and microglia, as something that may go out of control over the development of schizophrenia. And that points the light toward new potential ways of trying to develop treatments for schizophrenia.
So now moving forward with this knowledge, I think we can start to really think about ways to develop better therapeutics to...
So the bottom line is that they developed, what they did is they found the C4 gene, and the C4 gene is a gene that it tells the brain where, or tells the body where to prune, where to start cleaning up the brain during adolescence and young adulthood. And what happens is it mismarks. And so then the pruning becomes excessive and not where it's supposed to be. And that has been now connected, and we see it in the genetics of persons with schizophrenia. So we have known for some time that schizophrenia is genetic connected, that there's strong genetic evidence, but we never could find a specific cells. Because remember, it's not always a singular cell, but it can be something that's turned on with sleep, which we know that environmental factors do worsen schizophrenia. We know that there's a connection for some people with marijuana use. The hallucinogenics turns on, and we have drug-induced schizophrenia that turns on some of this. So it's like we've definitely come a long way in what we know. This is a TED Talk. I can't show it here. I can do it there. I could do it at the end. I don't know if we'll have enough time, but I have posted it for you. And she's absolutely amazing. If we have time, I'll do it. So with schizophrenia, not only do we have the delusions, and we also have some symptoms where the person has struggles with basic functioning because it's like by being socially withdrawn, that because of the disorder. Now here's a chart. Remember we did this for intelligence, and we looked at one of the ways that psychologists have been researching things around genetics before we had genograms. It was using twin studies. So here you see that the genetical predisposition with schizophrenia between identical twins, and then here is the highest connection, right? And then here we have both parents. So if both your parents would have schizophrenia, this is the genetical predisposition. Fraternal twins, right? Remember that's more like brother and sister. They don't have the same genetics. One parent. Siblings, so this is the chances of you having, right, the percentages. So here it's like 46% of, if you have an identical twin, has schizophrenia. So here you have the high end to an unrelated person or your spouse or niece, sibling, one parent, fraternal twins. So we know that, we always knew that there was this genetical predisposition. What we didn't know is what was the activity, what were the things creating it, and we now know that. All right, so moving on from schizophrenia. Any questions about schizophrenia? Anybody watch the movie The Beautiful Mind? Definitely worth seeing if you haven't watched it. It really kind of connects with yes.
Is there like a severity kind of like of schizophrenia?
Well, I guess depending on, I mean, like anything, it's like, he said, as Jay was saying, he works in a hospital, there are persons that have schizophrenia that are able to be medicated, and schizophrenia that are not able to be medicated. I mean, that would be one of the main ones, because, and Alan, the person who's a law professor, she actually was able to be medicated and could go on and function and have a very successful life. Obviously, if you can't, if you're resistant to the medication, and hearing those voices, and the quality of your life is going to be substantially different. Right? So that would be one difference. But of course, depending on when the pruning happened, if there was some mitigating factors, again, drug use seems to be worsening it. And for some people, I had one student had never used marijuana, and his mother was taking it for a disease, and so he tried it, medical marijuana, and he had a horrific experience with hallucinating, and he ended up going to hospital, and the psychiatrist said, you can never really take marijuana, like you can't take it, and that it can cause real issues for you. But he had a real negative experience to the hallucinogenics. Right? Okay, here we have a 30-year-old man presented for counseling because he felt that he was not managing his drinking. He reported that he would drink to reduce stress and to reduce his symptoms. Right? Stanley stated that he would he was tired and felt stressed. He would hear thoughts in his head that told him that he was no good. And sometimes, right, the thoughts suggested it would be better if he was not around anymore. Stanley stated he finds it difficult to engage in social activities. He feels strange doing so. He reports little energy or no motivation. Stanley states that he is groggy in the mornings when he drank too much, and did not want this because he was starting a new job. What do you think he's experiencing? Anybody?
Anxiety.
Anxiety? How many people think anxiety? He might be having a little bit of anxiety, but I don't think that's the primary.
Schizophrenia?
Depression.
No, he's not really having delusions or, but good guess. Depression, somebody said, yeah. So what would make you think depression? What parts of this would you think is depression?
Because he thought that he wasn't good for anything.
Right, right. So one of the key things we know about depression is almost all people with depression have negative statements. So when we compare people who are depressed versus people who aren't depressed, they have a lot of negative statements about themselves, right? So they have, you know, I'm too fat, I'm too short, I'm too, I'm not smart, I'm not being successful, I'll never be successful, no one likes me. Their overall state of thinking and their thoughts tend to be significantly less productive, like the very negative self-thinking. And so yes, he didn't have a delusional thought, but he had a negative thought, right? He didn't think he was so good.
And alcohol is a depressant. So.
And alcohol is a depressant, and often when we talk about comorbidity or concurrent, often people self-medicate. So he's not sleeping, and we know sleeping and depression go together, right? That sleeping can lead to anxiety or depression. And, by the way, often depression and anxiety are often together. So people don't just feel depressed or just feel anxious. A lot of people feel both anxious and depressed. That's why Gregor, that's why what you said was correct in that, because it did kind of just say a bit of anxiety. It wasn't as primary, but it definitely, you can feel both, right? So major depression is really extreme emotion of feeling depressed. There's different types of depression, and they have separated in the new DSM bipolar disorder out of with depression. So we have major depressive disorder, which is to do with how you feel. Now, everybody feels depressed. That doesn't mean they have clinical depression, but that means every single one of you today, this is the one disorder, like when I talk to you about schizophrenia, you can't say, oh, I felt that. Probably not. Have you felt delusional? Maybe if you didn't sleep for a lot, you might have had a bit of hallucinations, or maybe you've taken some drugs that made you feel like that, but for the most part, most of us don't feel that as a predominant feeling, the symptoms of schizophrenia. But everyone has felt depressed. Everyone knows what it is to feel depressed. But the difference is we feel it for a weekend. Someone breaks up with you. You feel it for a couple weeks. Right? You feel it for a very small period of time in your life, and you don't feel it all the time, or for extended periods, or in large magnitude. Having a weekend of feeling sad is pretty normal, right? Everyone feels sad. Sometimes it's just like, ugh, right? But that's not the same. But you can still recognize some of these symptoms. So when you're feeling that down day, not depressed, so here's some of the symptoms. Behaviorally, a loss of appetite, or changes in your weight. Gaining weight, a lot of times people who are getting depressed are gaining weight, a lot of weight, or losing weight. Sleep disturbances, well, we already knew that one, right, from last week. Motivation, interest, or a lack of energy, or lack of interest. Oh, do you want to go out? No, not really. Are you going to try to get your assignment done? I don't know. Right? So no real desire to do anything. Another, speaking slowly and moving slowly, right? So you're not moving none too fast, right? Difficulty getting out of bed. Well, you're all here. Thank goodness. It's pretty early, right? People with depression find going to first class is really difficult, right? Really hard to get out of bed. Cognitively, difficulty concentrating. Can't read, can't work, trying to struggle, right? Negative view of the world and self. That's the hallmark. Right? If you have a friend and it's like, God, everything out of your mouth is negative, right? That might be a good indicator that they may have a bit of depression, right? Or if you notice yourself, every time you're talking and it's like, oh, I'm of painfully negative, right? It's like that's a good indicator that there may be some beginnings of depression. Blaming yourself for everything, right? So everything's their fault. It's like it's my fault and I can't change it and I have no hope over it, right? An impairment in memory and an inability to concentrate. So, for instance, a lot of people think they have ADHD, and they may be anxious. If you're so busy about worrying about being embarrassed socially in class, you're going to be anxious, right? And so how much are you concentrating? Well, depression's the same way. If you're feeling so negative about yourself, negative thoughts, and you don't feel motivated, it affects your concentration. And so sometimes we have to rule out with ADHD, and why it gets diagnosed sometimes falsely is because it can be related to anxiety, depression. I'd say about when I was working in Center for Students with Disability, 50 to 40%, like 30 to 40% of the people I seen that thought they had ADHD actually had depression or anxiety. Yes, there was something not okay, if something was affecting their concentration, but it was more related to depression. So we have the behavioral changes, we have the cognitive changes, and now we have, with major depression, the physical symptoms. So headaches. So I think there's this really good commercial I see sometimes on TV about being depressed and the person's like sitting on the couch or laying on the thing and can't move. And it's like a bad case of the flu. Right? You actually, with depression, you don't think of it, but they actually can have stomach problems, headaches, constipation, dizzy spells, and muscle aches. And they don't sound like me, right? Who's been sick for 3 weeks, right? No, they actually don't have the flu, but they feel like they have that kind of achy, horrible feeling, right? So physical ailments. So, how many people, many people suffer with this and never receive treatment. Tons and tons of people never get treatment that have major depression. About 50 to 60% of people have reoccurred. So if you have one major depression in your life, chances are you may have another. Right, so you might get out of it and then you may have another. 20 to 30% of people with chronic reoccurring lasting 2 to 3 years. So you have one for a couple years, you might get out of it, and then you have another. Not fun. About half have attempted suicide. So obviously, when we talk about diagnosis and we talk about Robin Williams and head injuries, one of the things is people with depression are suicidal, right? And you may not see the pain that they're experiencing, negative thinking, but they are feeling the pain. So there is a biological basis to depression. It is not always about your life. So, I think the class asked, why do famous rich people want to kill themselves? They've got everything that we're all looking for, right? Money, flash, And it's like, why would you want to feel that way? Well, because your biology is making you feel that way, right? You have a chemical imbalance when you're suffering depression. Or they may have had we don't know every movie star's life history. They might have suffered from horrific trauma and be suffering from depression because they have very sad things in their life, right? So milder forms of depression, dysthymia, they can last for 2 years, but they have fewer symptoms, but they're like, bleh. So it could be similar to the major depression, but it's less, right? So just kind of not feeling like a lot of joy in life. And usually for a long period. So if a client comes to me they say, I think I'm depressed, right? And I'll say, well, how long have you been feeling this? And they'll say, is it forever? I don't ever remember a time in my life that I've ever felt this way. And a couple of times it got really bad for a couple of months, but most of the time I felt flat. That's what this would be. Persistent depression. It just never changes, right? And that's where you have, we call it, it's a milder form of depression, but it's not very fun, right? It's just like this flat. And I get very concerned about these folks. All right, so yeah, persistent depressive disorder. So and I think the key thing is chronic, right? The key thing when you're looking at persistent depressive disorder, dysthymia, previously called dysthymia, is this chronicness of like low-grade depression. The other type of depression is called SAD. I think that's fine. It's like, interesting. How sad are you? Seasonal affect disorder. I always put this on the test question, right? So seasonal affect disorder is where and it's not always just winter, although I've had many clients that have seasonal affect disorder. They do really great in the summer, right? And then as winter comes, they get really depressed. And so every year they have a time of year that they get depressed. And I had this one client, it was interesting, she would every year, she'd take her, so I'd start seeing her in April. I'd see her for a few bits, she'd get back on some medication, I'd send her back to her doctor, and then by November, I wouldn't see her, and she'd stop taking her medication because she felt amazing by, like this fall, and then she would get depressed again. And it was like, so I would say, okay, so this year, you're going to keep taking your medication through the winter and stop in the summer, and you're going to come to therapy in the winter and take a trip and get a lamp. Like there's these lamps that give you sun exposure. She started taking 2 trips in the winter every year, coming to therapy in the winter, not in the summer. Go have fun. She loved her garden, and it made huge differences. But it was like for her, she was doing the opposite. But as soon as she started feeling better, she changed everything, and then that didn't give her any protection for when she would be going into the seasonal affect disorder. Now, not everybody, it's common when we think of this that it's the time of year that people get depressed is in the winter, but that's not for everyone, right? And we do think it's connected to some of the sunlight and it's pretty dredgy up here, right? In this beautiful snow we have out there. Unless you're a skier and then you're like, yeah, man, it's like great, right? But people do have other seasons that for them, it's like their body clock. Remember that you have that body clock, that 24-hour body clock? But we have a body clock, and for some people, there's certain seasons in which that is really painful and difficult, and that their depression increases. And so that's called seasonal affect disorder. Any questions about depression? Yes?
This one's sort of a personal question.
Okay.
Because I don't know, I can relate to most of the symptoms that we call it, that you just went over.
Major, yeah.
Yeah, so from physical to being lack of motivation, to just being sleepy, having headaches and muscle aches and stuff like that. But the thing is, I'm not really negative at all. I'm usually positive most of the time. But all the physical and the other symptoms apply to me. I don't know, is that normal?
When I took abnormal psych, I remember way back, whenever I studied, most students feel like they have everything, right? So it could be that as we talk about these things, because we do, we all feel depressed sometimes. We all feel anxious, but doesn't mean that we have depressive disorder, right? So, and the thing is that we have to have it for a period of time. We have to have it, does it infect your life? Does it stop you from coming to school? Does it stop you from engaging in things that you like, right? Is it impairing your life? That's when it becomes a disorder. But if you're questioning it, we have people on campus. Why not go talk to them, right? That would be my, or you could maybe have the flu.
That too.
Yeah, I know I have all those symptoms right now, but I know I'm not depressed. I just am really quite sick, right? All right. But it's, it's good to be checking it out. It's a good question. And you really need to spend some time with the clinician and, work out and check it out for yourself, right? And I would say that to anybody in the class, right? And anybody you tell your friends, check it out. You know, it's like if you're feeling it, check it out and see what somebody else says. The fact you're not having the negative thinking is a real positive. Could be related to sleep too, right?
Yeah, my sleep schedule.
Sleep deprivation, yeah. But again, I don't want to diagnose you on the spot since that's not really what I'm legally allowed to do, so I'd say go to someone that can. All right. So we already went through seasonal affect. And, okay. So two disorders so pregnancy seems to be a time in which women are really vulnerable with depression. There's a percentage of women who have it after, and there's a percentage of women that have it before pregnancy, right? And generally, if you've had one episode in your life during pregnancy, the chances are in the next pregnancy you will also have it. And in Toronto, this became really relevant and became sort of in the public eye about how severe this was when a psychiatrist's daughter, who was a psychologist, jumped in front of a train with her 1-year-old, right? And they were both killed. And nobody knew, there was no signs of her being depressed in any way. She hadn't had recurring depression and was just one of these 3 to 6, and then had severe depression. And you would think, being a psychologist, I think what shocked her community, shocked Toronto, is that she was a person who knew about this, right? And so awareness wasn't the issue, and yet here she was at risk. And they actually started specific research at Women's College and made some major changes around doing some research and making better community programs available to women after they've had their children and before. So we have much better facilitation of community nursing programs for after the birth of a child, with breast clinics and breastfeeding clinics and stuff, because there is a huge risk when women have pre-pregnancy and post-pregnancy, right? So definitely, and for me, I've treated several women who have had this, and actually I've treated women who their first episode of depression was after pregnancy, and then never and they often didn't even come for treatment up to 5 to 10 years later, but the first episode started here. And it's and yet they try to push through it, and then came for treatment later in life. So that's definitely a high area. So bipolar disorder, again in DSM, just like anxiety and OCD, was separated because they felt that the disorders, when they were clumped together, really didn't reflect the truth of the disorders. By separating them, we can do better research and better understanding. So bipolar disorder is where there's different types. One is where you have full mania and depressive symptoms. The other one is you have major depression and mild mania. So bipolar is where you have a mood disorder. So instead of having an average mood, you go really up or really down. And so instead of having within a normal range of mood, so we all have ups and downs, but this is really up and staying up. You'll see these people on I think the guy who's gold, 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 right? It's almost hyper and really excited, right? Don't you want gold? What is his name? Gold, 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 right? So bring me your gold. Right? No, don't bring me your gold. Oliver, yes. Oliver seems very manic, right? And so people with manic depression, and it used to be called bipolar disorder, but now it's called, what did it used to be called? Anyway, I can't remember. I'll tell you later, next week, when I think I've been. But bipolar disorder has a manic stage and a depression stage, and so you can have one or two, and it's the opposite of how long you go through. And usually you go through this in months, 2 to 3 months. So sometimes people say, oh, you're manic or you have bipolar disorder, but you actually may have borderline personality disorder. Borderline is days. In the same day you go up and down. This is over weeks and months that you go up and down. Most people are not hospitalized in the manic stage. Can you imagine, like, you know, if you're like, woo, you're not often like really jazzy, people don't hospitalize then. It's in the depressive stage that they hospitalize. But in the manic stage is often where people cause a lot of disaster in their life. And I put a video, it was a self video of a girl named Laura, and she would like shop. And so a lot of times clients will come to me with this disorder, and it will be their life is in chaos because they kind of like, when they're in that manic, they have no kind of impulse control, and they just do what they want to do, and it's like fun, and they're out partying, and then all of a sudden you crash down and you have the depressed side. A lot of times there's a big connection to sleep. So they don't sleep in the manic. Don't sleep, go out partying. They often will use multiple substances. That's a big issue for this disorder, right? So that's just some of the kind of areas. And then the depression can be very drastic. And they have this drastic mood shift. And then become quite suicidal at that time. Often very genetic, runs in families, mood disorder that runs in families. Okay, so I'll skip through that. The manic, you guys understand what the manic is? Okay, personality disorders. So somebody already talked about a personality disorder, I think it was you, Tracy, that somebody was mentioning about a friend who had been diagnosed, once depression and then anxiety, and ultimately it was a borderline personality disorder. Okay, yeah. So what happens here is personality disorders are not really diagnosed till adulthood because we know our personality can develop as children. And so, but what you find with personality disorders is that there's a pattern which that person has abnormalities or effects in their personality that affects their mental health. Generally with personality disorders, they may not even come for treatment, but it's everybody else that notices their personality, right? So they kind of leave, it's like how they're impacting other people. And so they're sort of maladaptive, they are inflexible, they have, impairments in functioning in particular areas. And there's clusters in personality disorders, and they differ across culture. So here's the main clusters. So there's these odd behaviors, which are, they have paranoid, schizotype, right? So this individual is so a little bit of the grandiose that you'd see in a person with schizophrenia, but in that person, they're having delusions. This person is just odd, and they're highly suspicious. They might be collecting stuff, or they're very untrustworthy, hypersensitive to the environment, and they do these odd behaviors, right? Cluttering, that kind of stuff. Although we know now that hoarding they have a new category for hoarding under OCD. So that was the new category in the new DSM. So then the next one is overtly dramatic. So borderline, hystonic, narcissistic. So for instance, narcissistic, individual exaggerated sense of self-importance. I'm so great, right? I'm wonderful. Didn't you know? Right? And then we're not talking self-confident. We're talking about somebody who's really uncomfortably arrogant and really likes attention, right? Borderline is where you have these drastic mood, but it could be in the morning, in the afternoon, and then dinner. So 1 minute I'm really sad, next minute I'm going out with my boyfriend, everything's wonderful, it's amazing, and then you're back to crashing, right? Often it's really hard to keep up with these people. They have a bit of self-image, that kind of stuff. And a lot of new kind of therapies called DBT. It's a difference in from CBT that's been amazing at helping people with borderline personality disorder, new treatments. And then the last group are your obsessive compulsive personality disorder. So this is not where you have obsessive compulsion, and you can have obsession or compulsion. This is where it's your personality. And I had a student once that had this, and I describe it as, I'll show you, it's like this kind of person, it's like it's not enough. They have to, it's like perfectionism almost. And they would, you could color this way, but they get so stuck on coloring it perfect and coloring it and getting obsessed that they wouldn't get it done. And so these kind of people will be so obsessed that they're not getting their homework assignments. You know how it's like your assignment's okay, you might get a 60 or a 70, but it's not perfect, but you just get it in because it's due? Well, these guys wouldn't be able to do that. That would be really tough for them. So this individual is concerned about doing things the right way, generally perfectionistic, and relationships are emotionally shallow, right? So each personality type is sort of a description of a personality with sort of odd, outside the line behavior. And it doesn't necessarily impair their life, but it takes away from their life. It can be impairing, but it doesn't always have to be, right? Often it affects others more than it affects them. They are used to their odd behaviors, but in their course of their development, we believe that they develop these coping strategies or these obsessions on certain things and developed a style. Now, in the new DSM, do you remember the big 5 we did? Conscientious, extrovert, introvert. So they've done a new trait theory, and they're running it at the same time as this, where we have different traits, and you can kind of see some of the traits in here if you're really conscientious, right? Or you can see some of the traits of dependent personality, doesn't want to take risks, right? And so what they're doing now is they have this running for diagnosis at the same time as using the big 5 trait theory, and they're subdividing it because they don't believe these categories are all that helpful. So these categories of oddness tell us what they look like, but they're not that helpful, they believe, for treatment. So what's the difference in treating a dependent personality from a schizoid personality disorder? What are the features? How are you going to treat it? And so what we're looking at now is at the big 5 personality, so that if we can change a trait in your personality, then maybe you wouldn't be that odd that way. And so that it will be a more effective method for treatment and will be less labeling. So again, when we had the discussion about labeling, it will be less labeling around a diagnosis. See, again, even when we talked about multiple personality, we got rid of the label because it had a negative connotation. So the same way here is that, do these labels really help us? Are they helping the client? Or is there another system we could use? And so right now they're doing experiments and they're collecting data with the personality trait theory to see if there's traits and someplace on the trait that we can actually identify these. And that's the new personality theory. Can you start to see how different personality disorders are from anxiety versus depression versus schizophrenia? Can you start to see what are the hallmark differences in these different kind of key disorders that I'm presenting to you? Does it make sense to you a little bit, or any questions? I think it's really interesting stuff. Oh, this just goes through the clusters. All right. So, any questions? Yes.
The test on January 16th, what chapters is it going to include?
It's going to be sleep, right? Altered states, which is chapter 4, chapter 13, and chapter 14. And we're going to do, when we come back, the first week,
chapter 14 on?
Therapies.
Oh, okay.
So we're going to do therapies on the 8th. Is that the Monday, the 8th? Yeah, so we're going to do therapies on the 8th. And then on the 15th, we'll do a test review and have the test in class. And we're going to do the test in hard copy in class. All right? Have a good holiday. Anybody have any other questions?
There are no more major assignments due?
No. There's nothing due before Christmas. I might extend anybody who didn't get the journals in. And all you have is I have to post them, the quizzes. No, he'll want you not doing anything over the holidays. If you haven't got if you haven't got the last set of reflective journals in, let me know. I'll extend the dates. I know you guys are busy. Hi. Sure, we're still being taped. Yeah.